Good afternoon. We are going to have a wonderful discussion because I know it's post-lunch and everybody's metabolism is going. As Bledden mentioned, my name is Irene Aninye. I'm the Chief Science Officer at the Society for Women's Health Research, where we are dedicated to advancing women's health through science, policy, and education, while promoting research on sex differences to optimize women's health. Obesity is a chronic disease that disproportionately affects women and affects women differently than men. So it's clearly a topic of interest in the work that I do at SWHR, but that's for later. This morning, as Bledden mentioned, we talked about these non-communicable diseases, how they have this ripple effect on an individual's health. And so this afternoon, we want to look at the role of the health systems and primary care to address the chronic care integration in our health systems, as well as key considerations and best practices and areas for improvement. And so we have a stellar panel today that has a very diverse expertise across research, clinical care, business, policy, and patient advocacy, and is sure to be a nice rainbow of insight that we will collect today. So I'm going to read a brief of their bio so that you know who we have at the table this morning. And then we will hop into discussion. So first, I'll call Dr. Bruno Halpern. He's the president-elect of the World Obesity Foundation and chief director of the Obesity Center for Hospital 9 de Hulo at Sao Paulo, Brazil. With a background in endocrinology and metabolism, Halpern's research studied circadian rhythms and brown adipose tissue. He believes that education and credible scientific research are paramount to improving obesity care and reducing stigma. And his work to propose a new method for evaluating clinical outcomes in obesity treatments is now used in medical schools and by the Brazil Ministry of Health. Dr. Halpern serves the editorial board for clinical obesity and is the endocrinology PI for BR Trials, a clinical research center in Sao Paulo. So if you welcome him to the stage. Next, we have Lisa Schaffer. She's Executive Director for Obesity Canada, an organization with a mission to improve the lives of Canadians living with obesity through research, education, and advocacy. Starting as a dedicated volunteer for nearly 8 years, she served as a patient advocate, chair of the Public Engagement Committee, and member of the Board of Directors for Obesity Canada before becoming the ED. Lisa's authentic and innovative approach to solving business challenges has made her a standout leader in the community. She brings over 30 years of leadership experience across diverse industries with a proven track record in strategic relationship building, sales and marketing, operational excellence, and human resources. Let's welcome Lisa. Next, we have Dr. Marius Geanta. Did I say that correct? He is co-founder and president for the Center for Innovation in Medicine, a non-governmental organization based in Bucharest, Romania, that works to shorten the time between emergence of innovations into the medical sector and their application for the benefit of patients everywhere. Dr. Geanta is a pioneer in the field of personalized medicine in Central Eastern Europe and is involved in the Pan-European innovative healthcare projects such as DigiTwins Consortium and the Public Health Genomics Network. With more than 15 years of experience in health and science communication, he has been a publisher and editor-in-chief for many medical journals and health communication platforms. As president of the Center for Innovation Medicine, Dr. Geanta organizes high-level events such as Science Meets Politicians and the Personalized Medicine Conference. Let's welcome him to the stage. Next, we have Sarah Brocq. She's the founder and director of All About Obesity, with a unique skill set of living with obesity, a background in science, and 16 years of experience working in the pharmaceutical industry. Among her many active roles, she is also a strategic council member of the All-Party Parliamentary Group on Obesity and a steering group member of NHS England's National Obesity Audit. A leading obesity advocate in the UK, Sarah is passionate about changing the narrative around obesity and works to help remove weight stigma across society so that people living with obesity will be treated equally. Let's welcome Sarah. We also have Greg Perry. Director General, Global Self-Care Federation, with over 25 years of experience in the pharmaceutical industry and international public affairs. He has driven transformative change through strategic leadership, cross-sector collaboration, and a focus on societal impact across Geneva and Brussels and between Europe and Africa. His experience spans public health, pharmaceutical innovation, and access to medicines. Committed to sustainable, socially focused solutions and policy initiatives, Greg is a recipient of the Golden Cross of Merit of Poland and his contributions to the European integration and industry development. Let's welcome Greg. And online we have joining us Dr. Amit Thakker. He's the executive chairman of Africa Health Business, a health consultancy, advisory, and investment firm that aims to improve access to quality, affordable health care in Africa. A medical doctor and visionary entrepreneur, Dr. Thakker has been a groundbreaking pioneer in the integration of private sector within the healthcare system in Africa. He actively supports governments, corporations, health organizations, and development partners to foster effective public-private partnership initiatives towards improved health outcomes. He has also served as the director of the AMREF Flying Doctors Action Aid in Kenya, 7 Seas Technology, and East African Business Council. Welcome, he's online. See, he's up on the screens. So I'm going to take a seat over here, and we will do, and I wanted to be able to do these bios so that you know who's on the stage, and we're just going to jump right into them being able to share a little bit about the work that they specifically do and how it intersects with primary health and health systems, that intersection with obesity. And so we will start with Dr. Bruno Halpern.
Thanks, Irene. It's a pleasure to be here today. I'm representing World Obesity Federation. As you said in my bio, I'm a clinician by formation, so I work mainly with patients. And during my formation, that I was always interested in obesity. I think it's a very understudied area. What we see is that a lot of people with obesity, they have other chronic diseases, and they are going to the doctors to be treated for those other chronic diseases, and there's no discussions on obesity itself. So sometimes the doctor can say, oh, go there and lose 20 kilos, and then you come back, you improve a lot of comorbidities and so on. And of course, it's not easy to do that. But the obesity as a disease is not being discussed, like it's just something related to eat better, go to do physical activity, but it's not a direction on what is exactly the disease you have, the disease of obesity. And we are and now I'm working more with the World Obesity Federation. Of course, I'm the president-elect, and as World Obesity Federation, we are very worried about the declaration of NCDs that, again, will not recognize obesity as a disease. And if you don't have the problem, you cannot have the solution. So, and I think that's the main focus, in my view, that we should discuss here. It's how can we, in some ways, integrate health systems in the way that someone go to the doctor to be treated due to hypertension, diabetes, and there's a good discussion on obesity and not just what you're going to eat, what you're going to exercise. A woman breastfeeding, if she's going to her doctor, we should talk about her obesity and the risk for the offsprings and so on if you're not going to treat. And the way we should integrate this is through recognition of the disease, and that not only it's one of a lot of other diseases, but is the main driver of many other diseases. We have now data that have shown that if you treat correctly obesity, you can prevent almost 99% of cases of type 2 diabetes in the long term. So if we don't focus on it, we are not going to have this result. So we are very worried about this declaration. And I think that the main focus here should be exactly on this education, of course, of healthcare professionals in some ways, but in a way that every patient that gets to a doctor can be offered treatment for their obesity if, of course, they want to, in a respectful way, and in an easier way. We are talking a little bit about prevention as well, and when we talk about prevention, we discuss a lot about sugar taxes and so on, and it's important to have it, but it's important if we have ways to reduce the price of good food. You know, like we should have solutions for the people living with obesity. They should not be punished by new taxes, but they can have, it could be easier for them to eat more fresh food and so on, and to make healthier choices. When we discuss a little bit about labeling as well, there's a lot of discussion, let's interpret this labeling. No, it should be easy to them to make healthier choices. So I think that's the main beginning, main background I want to talk about, and I'm sure we're going to discuss this further on. Thank you very much.
Thank you very much. And Lisa?
Awesome. So thank you, everybody. And as my intro led you to believe, I am the Executive Director of Obesity Canada, and I'm incredibly proud of the role that we have played in the landscape of obesity and understanding obesity as a chronic disease. Obesity Canada has been around for 2 decades now. This is our 20th year. And we've been at the heart of really building the foundational understanding of obesity as this chronic and complex disease. And thank you for saying it the way that you said it as well, because I think that's really the root of everything that we do as well. We have to have the level of recognition to be able to move forward to find those solutions. And the fact that we still have to talk about the recognition and remind people that it is a chronic disease unto itself is part of the challenge that we all face. But Canada has contributed a lot to the leadership and the foundations around obesity, including Dan Drucker's work that paved the way for these GLP-1 therapies. We've really shaped clinical voices, and we've really informed the field around the world. But despite that, and although I am deeply proud of being Canadian and that, you know, universal coverage and that we have this great healthcare in Canada is part of our identity, the reality is for those of us that live with obesity, it continues to be a challenge, a struggle, and a real patchwork of information. To echo what Joe was saying earlier in another panel, you have to fight for yourself. The level of self-advocacy that you have to do in Canada to get to solutions, and the fact that I'm informing my own healthcare provider along the way, while powerful and I feel great about that as an individual, is a challenge, and we can do better. And I think that's really the big heartbeat of what is behind Obesity Canada, because the challenge really is bigger than obesity. And what I love about part of the conversations I've heard today, it's about challenging the systems to change more than what we need the people to do to change. And I think that I love where we're at this moment in time, and I'm going to use the word of the day, collaboration, is what's going to help move all this forward, because we need to think differently. To quote my dad, a road would only be as wide as a horse's ass until somebody thought differently. So I feel like we're at that moment, shout out to Dawn, that, you know, we need to start thinking differently and widen the road and really challenge ourselves to approach with innovative solutions. To that end, things that we've done at Obesity Canada that, again, I'm incredibly proud of being near and around, we have developed the Canadian Adult Clinical Practice Guidelines. So our clinical practice guidelines are very powerful. They're fantastic tools that really help disseminate the right information, and truly we're the first in the world to truly classify obesity as a chronic disease. And as a chronic disease, provide solutions and inroads and information for people to be able to then take forward and move into implementation. We still need some more collaboration around implementation strategies, which is why we're all here this week as well. But those guidelines are really a foundational piece, I think, for many people. We're incredibly proud that they've been globally adapted and adopted as well. So we know that we're influencing far and wide, and that feels fantastic. The other thing that Obesity Canada really does that stands out in this field is we come from our roots of being called the Canadian Obesity Network, and we truly understand the power of partnership. Our founder, Dr. Arya Sharma, if anybody has ever met him, knows the power of partnership and the power of influence and networking. He's the first person to bring two people together and say, you guys need to talk, and you guys need to know about this. And that has very much informed how we operate as an organization as well. We love to be bridge builders. We love to share our clinical practice guidelines. We want to foster these kinds of relationships. And what is truly at the heart of all of it is the patient voice as well. We know that lived experience has a lot of power to it. And by bringing our voices to the forefront, we're able to help move those potentially dusty clinical practice guidelines from something that sits on a shelf to something that really connects with human stories and moves things forward. Because we also know that is really at the heartbeat of change. When we connect this to human stories and experiences, there really is so much more motivation to make change happen. And that's just a little snapshot of who we are at Obesity Canada and why I'm really excited to be part of this conversation, because we're interested in thinking differently and making these inroads and these connections wherever possible.
Thank you very much for the invitation, first of all, and thank you for putting so much accent to think differently. This is what we are actually doing at the Center for Innovation in Medicine, InnoMed, for 11 years. And one example is a project I coordinate called 4BCAN. This project is an EU-funded project coordinated by InnoMed, and the idea was actually to create a different model for the implementation of the public health interventions. So the classical way of implementing a code against cancer, an anti-smoking campaign, a public health intervention is to go from UN, then to go to WHO, then to go at the national government, then at the regional public health authority, and finally at the family doctors. Usually what you can see in a family doctor office, at least in Eastern Europe, is a leaflet with some recommendations on a wall, and at the end of this very long process, we're actually waiting for the people to change the behavior. And simply doesn't make sense. And doesn't make sense because if you look to the health determinants, actually only 10% are related to the health systems. Around 50% are related to biological and genetic factors. Very few are environmental factors, but the large majority, around 60%, are behavioral and social factors who are not properly included in the design of the interventions. And considering all these things together in the project that I mentioned, we are working now to create a bottom-up model for the implementation of the European Code Against Cancer. This European code, who has a version, a Latin Code Against Cancer, consists of 12 recommendations, and one of them refers to obesity. And we, in a small village in Romania, we created a living lab, Lărești Living Lab. And the term was mentioned today coming from Belfast. And this is a setup who allows you actually to experiment, to go in a community, to use, and we are using advanced social sciences to understand what is actually happening there and what are the nodes, what are the best ways to try to influence, in the context of our today discussion, the obesity. This is part of the implementation science, and in the previous panel was discussed about how important it is to put more attention and funding to the implementation science. This is very clear. And in this living lab, what we did initially was to use the pentahelix model of collaboration of the stakeholders. The topic of our session is linked to the health systems, but the health systems are only one out of the 5 parts of the pentahelix. The others are the public authorities, private companies, civil society, and academia. So if we like to change the health system, we should put the discussion and actions in the context of the pentahelix. I mentioned already that we use advanced social sciences, and in particular network science. And what we did was to apply a methodology called NetMap to the pentahelix, trying to not only to identify stakeholders, but to understand different relationships between them in terms of collaboration, cooperation, funding, and this was very interesting. At the beginning of my talk, I spoke about 6 stakeholders involved in the top-down implementation of different campaigns. But we identify 130 stakeholders at global, European, of course, national and regional level. And we not only identify a big number of stakeholders, but we identify who are the most relevant. And from this perspective, and I think Mark mentioned how important it is to start working with the local governments, we identify the local authorities as a key stakeholder in the process, but usually neglected. And our activities actually involve the local mayor and local council in the activities. And another part of the use of the social sciences in this project is the personal network analysis. And we have a cohort around 130 people, 4 waves of data in the last 2 years. And from obesity perspective is very interesting. And I'm quoting now a paper back in 2007 saying that obesity spreads through social network. So in other words, my risk of being obese increase with the number of the people with obesity from my network. And this is a very interesting finding coming from our study. And the second is around perception. If a person is suffering of obesity, the perception about the other persons in the family, the perception about obesity is not at the level required by the physical measurement. It is the tendency to underestimate. And this is important because if you are exposed to obesity many years, and this starts with what is the most important for you, right? The opinion of your family members. This exposes you actually to a very long period of inaction in relation to obesity. So these two findings coming from social sciences are very important. And the third point, and I will stop then, we actually identified clusters at the community level in terms of geography, in terms of social, behavioral, and medical clusters. And this is very interesting because in this village, majority of people are elderly people. They have comorbidities, 3 or more other diseases, multiple long-term conditions. So they basically have cluster of diseases, cluster of risk factors, and clusters of behavior coming all together. So, and we'll probably have the chance to discuss about implementation, about interventions, and how these findings can actually inform more efficient intervention at the community level.
Thank you. I don't normally write notes, but I have because I've got a tight time frame to stick to, and otherwise I'd go off on a complete tangent. So I'm going to try and keep it together today. But thank you so much for having me here today. I'm delighted to talk to you today all about obesity and the work that we're doing in the UK. We're a not-for-profit organisation, and we're committed to changing the conversation around obesity and improving support for people living with the condition. This was born out of a passion that I had for myself, and having experienced kind of having very little support and care for myself growing up, I kind of wanted to make a difference. So that's where All About Obesity was born from. Kind of our mission is rooted in the belief that obesity is not simply a matter of individual choice or willpower, but it's a complex chronic disease that requires coordinated action across health systems, primary care, communities, and policy. the main thing that we focus on, and I think it's the biggest hurdle that we have in anything that we do around obesity, is reducing stigma, but also raising awareness of obesity. So one of the central areas of our work is challenging the stigma, because it so often surrounds obesity, and too often people with obesity encounter judgment when they access primary care. Sometimes just being told to eat less and move more is the general narrative, and I've had that time and time again over my lifetime. But this not only fails to reflect the scientific understanding of obesity that we have now, it also discourages individuals from seeking care early, and this is where support could be the most effective, actually, if we break it down. At All About Obesity, we partner with clinicians, patient groups, and the media to improve understanding of obesity as a medical condition, influenced by biology, environment, and social factors, like we've just been hearing about. And by working with primary care providers such as GPs, practice nurses, etc., we help equip them with the language, because that's really important. Language is so powerful. Tools and training to have compassionate, constructive conversations. Because what we hear and have done for years is these conversations being thrust onto patients, people around obesity, and people aren't wanting to always have those conversations. So we have to respect it. And I always quote the Canadian guidelines of you must ask permission. So the 5 A's, asking permission to have a conversation about someone's weight is the most important thing that you can do. Because what we found is that when stigma is reduced, people are more likely to engage with services, they feel supported in their care, their journey, and they adhere to treatment plans. And in this way, primary care becomes not just a gatekeeper, but a trusted partner in long-term prevention and management. I think it's really important. We also really advocate for supporting access to treatment and health system change, because another key strand of our work is advocating for equitable access to treatment, because in the UK, as I know with lots of other countries, we don't have that right now. Access to obesity services is patchy and often dependent on where you live, very much a postcode lottery. We have specialist multidisciplinary weight management clinics and bariatric surgery clinics, but they're not consistently available across the country. And then primary care is left to fill a gap without adequate resources, which is a real challenge. So we work to ensure that people living with obesity are offered a full spectrum of care, from prevention and early intervention in primary care through to evidence-based treatments, including medications and surgery where appropriate. It's not for everyone, so it's about making sure the right person gets the right care and you meet them at where they are. And importantly, we encourage health systems to view obesity care not as a one-off intervention or a 3-month intervention, but as a chronic disease management similar to diabetes or hypertension. And we're definitely not seeing that happen enough yet. So, for example, we've collaborated with NHS trusts and commissioning groups to highlight best practice in integrating obesity pathways where we have seen it, and a GP who is supported with clear routes, shared decision-making tools, and ongoing follow-up is far better placed to help patients manage their weight in a sustainable way. This system levels approach also has clear implications for prevention, because by embedding obesity management within routine primary care, such as blood pressure checks, diabetes risk assessments, asthma reviews, etc., we create multiple touch points where healthcare professionals can identify risk early and offer tailored support to that individual. We also, and I suppose more importantly, and it's great that Lisa and I are both on a panel together today, is we elevate the patient voice, which I think is really, really important, because finally, a place where people with lived experience of obesity at the heart of everything that we do is really important, and having us involved in things like this is really important. So thank you for having us. Too often, policy and service design are made without input from those most affected, and so therefore we create all these things that we think are brilliant, but they don't work because they haven't been created with the people that we need them to be. And our patient ambassador shares their stories with healthcare professionals, policymakers, and the public to highlight both the challenges and opportunities for change. And I think it's important to highlight the opportunities, because I think sometimes we talk about the challenges and the negatives, but actually there's lots of opportunities and lots of solutions, but it's about working together to create the best ones. And I think people's voices remind us that health systems and primary care cannot simply focus on weight loss and weight loss targets, which they have done for such a long time. They must also consider things like mental health, social support, and quality of life, because patient-centered approach is essential if we are to build trust and to truly improve outcomes moving forward. So I guess in summary, kind of All About Obesity and my organisation works to shift the narrative from blame to understanding, from fragmented provision to a system-wide care, and from exclusion to inclusion of people with lived experience. By strengthening the role of health systems and primary care in prevention and management, we believe we can reduce stigma, improve access to treatment, and ultimately support healthier lives for millions of people in the UK and beyond. So thank you for having me today.
I'm going to pick up on one of the things that you just said straight away, which was how a lot of concepts or ideas or systems fell because they didn't have the people that are needed to be involved in it. And I think that is such an important part in the way of which we want to look at innovative approaches to health, which will nicely leads on to what I want to talk about, which is self-care and its role, particularly in the link between freeing up resources in primary healthcare. But let me just explain firstly my organization, so the Global Self-Care Federation. We are that part of the life science industry that focuses on innovation and development and manufacturing of medicinal products, non-prescription generally, and personal health products, most of which is available in a pharmacist and sometimes other in retail outlets. Now, the definition of self-care by the WHO is along the lines, because I can't remember it exactly, but is along the lines of enabling the individual, the family, and the communities to promote health, to prevent disease, and to cope with illness or treat illnesses. Now, sometimes that is often seen as getting fit, eating properly, doing yoga. That's fine, yeah? We can all do that, and that relates to any form of disease or condition, yeah? What we focus on is providing the tools and the products that enable people to carry out self-care. And I'll break that down into two sort of areas. The first area is a whole series of non-prescription medicines. And these include, for example, tobacco cessation, nicotine replacement. It includes, for example, oral health. So that's very simple, straightforward, access to fluoride toothpaste, brushes, wash, etc. It includes sun creams, sun blockers. Now, why I'm raising all of these is because these are all to do with NCDs. All of these to do with cancer. These are very easily applicable, very easily available, and they're low risk and high impact. So the idea is the more that we can use of these as individuals and think about the consequences of not using them, we can actually free up a lot of what otherwise would end up in severe primary healthcare situations and then secondary care. Another area that I think is very important to mention, for example, is a whole series of diagnostic materials, also new AI and digital options that enable people to look after their health. What's important, though, is when we talk about self-care is that it says about the ability, but what we need to do is provide the environment that people are enabled to do it, which means we have to have greater access through pharmacies. We need to have greater access and the development of new digital and AI health in order to do that. Now, the point I mentioned at the beginning is what I think is the great opportunity, and if I can use the road, and we need to make it bigger than a horse's ass. And new innovative, I do like that word. And we need to, so sounds a bit politically incorrect somehow, I don't know, but anyway. So widening the road is we need to think differently. And I think that if we start to think about self-care and self-care options, and I'm not talking about just putting all the responsibilities on individuals. It means creating the opportunities and supporting individuals. And as individuals, being able to have access to a lot of what's available in a pharmacy rather than having to go to the doctor. And this is the issue. The healthcare systems, we all know, are under unprecedented stress. yeah, and we've got to find some solutions. And it's going to get worse. We know for lots of reasons. Another thing is, I was at a meeting yesterday, there's climate change, and we're going to have greater problems, respiratory problems, hydration problems, and skin problems through the sun. And we've got to be able to get people to understand that you can actually do a lot of these things through what's available in a pharmacy. And you don't have to keep going to the doctor. Because what my vision is, and why I've come in, I'm quite recent, I've been there 8 months, why I wanted to come into this industry is because I feel like this is an amazing opportunity to create headroom for primary health care. We need to create headroom so doctors in primary health care and others can focus on areas where maybe prevention is not possible, or where a disease such as obesity, which is a chronic disease and totally misunderstood, needs to be focused on. So we can use the profession of doctors and specialists, free them up so they can deal with these sort of issues, rare diseases, for example, which has nothing to do with prevention. It's genetic. We need to be able to find a way in which to release the primary healthcare system to do it. So that's why I think, and I believe that's why I was asked to be here, is to talk about how we can look at a new way of integrating areas around self-care, non-prescription medicines, personalized medicines, or personal medicines, I should say, as a way of freeing up the health system so as we can focus on other things through that.
Thank you so much. And we will now go to Dr. Thakker online to provide your intro. Are you?
Thank you. Can you hear me?
Yes, we can.
Okay. First of all, I'm sorry I can't be there with you in person, but I'm really delighted to share this panel with some great speakers, and I know I'm going to learn a lot from all of them. I want to thank GHC and all the organizers for bringing me on to the screen and giving me a chance. And I suppose one of the reasons I was asked to come was to bring the perspective of emerging countries and specifically Africa, where I'm based. So greetings from Nairobi, Kenya. It's a little bit later than where you are. And I run a company called Africa Health Business, where I'm the executive chairman. I also am the president of Africa Healthcare Federation, which is like the chamber, the private healthcare federations of countries, about 28 countries in Africa. And I am really delighted to talk about this subject. I'll tell you why. Because for a long time it was seen as a complex condition for high-income countries. And over the past few years, you've seen that even Africa, middle-income and low-income countries are facing the brunt of this complex and chronic condition. And obesity needs to be dealt with now in places like this continent early on. So having Lisa and Sarah there, who've got years of experience, it's very critical for us to take on the learnings and not make the same mistakes that the other countries have made that have started affecting a community or ecosystem quite a lot in some cases. So Africa Health Business is a management health consultancy firm. We work in about 30 to 40 countries across Africa. We're also an investment advisory firm, and our role is to galvanize the entire ecosystem to improve the health of the continent. Specifically on this topic of obesity, there are 4 players we continuously work with. One is the providers, we constantly engage providers, be it public or private, to be very clear about preventive care and starting from the first contact. Of course, healthcare starts at the homestead and not at the hospital doorstep. And so this kind of conditions need to be having awareness right from the word go. So raising awareness is a great way of dealing with this condition. It's something we'd like to invite partners to join us in Africa, where we can have a lot more stakeholder engagement and awareness. The second group of people we deal with is payers. There is a huge push by many countries towards UHC, and we are quite far away from adequate coverage. So it does sometimes become rather expensive, and out-of-pocket expenses become even another barrier that makes dealing with this condition extremely difficult with some of the clients. The third group we deal with is suppliers. And talking about pharma here and diagnostics, we are very, very cognizant that there are newer technologies, newer methodologies, use of AI. We need to embrace these digital health solutions and newer innovative approaches to start using them as early as possible. And the fourth group that I want to talk about is the health partners. And earlier, I think when Bruno mentioned about the pentahelix, which includes the academia and CSOs, and others. So Africa Health Business plays a central role in coordinating with partners in different countries. We work with public and private sector. We even push PPP ideas. So as I pass on this back to the moderator, I wanted to mention that we have noticed as well the rise of CVDs, cardiovascular diseases, diabetes. We also, with the patients or the people who have obesity, and that's also a concern because that's giving also a cost to our health systems. I also want to mention during COVID, there was a big discussion around the link of obesity and comorbidities that were more frequent with people who are obese. So I like the word collaboration. We've been calling it collaboration is the new innovation. And today I've learned collaboration. And I'm looking forward on how to collaborate in order to make us in Africa even a more resilient continent and learn from the champions who've been through this and start adopting those methodologies across the continent. So looking forward to that. Let me pass it back to the moderator. Thank you.
Thank you so much for that. And I actually would like to invite Dr. Michael Makanga up to the stage to join this panel as well. Dr. Makanga is the Executive Director of the European and Developing Countries Clinical Trials Partnership Association. He's a clinician scientist with nearly 30 years of health and clinical research experience in Africa and European institutions. The medical degree from Makerere, you can take that final chair. University, a master's and PhD in pharmacology and therapeutics from Liverpool University, and the School of Tropical Medicine. He is a fellow of the Royal College of Physicians of Edinburgh. And so since he's just joining in, we were doing about a 4 or 5 minute brief on the role of your work in addressing obesity in primary healthcare systems.
Thank you very much for this opportunity, and good day, ladies and gentlemen. Thanks to the organizers and fellow panelists. I come in, the organization that I lead, that is the Global Health EDCTP3, has been in operation for the last 21 years and is involved in the development of medical interventions against infectious diseases through clinical development, that is through all phases of clinical development, and also the product-focused implementation research. We also cover the interaction of these infectious diseases with non-communicable diseases. And at this time, Africa is at an inflection point where we are now having the dual burden of disease. We happen to work with over 40 countries in Europe, in Africa, and 30 of them are members of the association, and 15 European countries that are involved in this. this dual burden of disease is really a thing that is on the increase, and we cannot neglect it at all. And what I stand for here is to reframe obesity and multiple morbidities so that we tackle them in an integrated manner. When we look at the health systems in Africa, they are really burdened and they're ill-equipped to handle this in a siloed approach. And in this, we're advocating for primary health care being at the front line of resilience that requires the integrated approaches. And the part that we are playing in this case, as an organization, one of the things that we are doing is that, having realized the need for integrate, is we are paying special attention to address major unmet needs, especially for the underserved populations. We see that a number of the people that have been impacted by the infectious diseases are very susceptible to non-communicable diseases. We've seen that in the situation of COVID-19. We are seeing it in the situation of HIV, individuals that are on long-term therapies, individuals that are on TB treatment. And in this case, what we are doing is to ensure that we train the workforce in such a way that they can be able to appropriate the expertise to handle both infectious diseases and non-communicable diseases. But more importantly, to ensure that we do research that addresses the interaction between infectious diseases and non-communicable diseases. We've seen situations where, for instance, in the global north, we've seen that a number of people that were susceptible to COVID-19 had a number of underlying factors, socioeconomic factors, social determinants, and yet the situation is a little different from the African side, in which case context-specific research that addresses these matters is very important. We are also investing in the regulatory environment to ensure that the regulatory investment accommodates both infectious and non-communicable diseases to be able to support the clinical trials ecosystem in an integrated manner. Because the same research centers that are dealing with infectious diseases are the same research centers that are also dealing with non-communicable diseases. And obesity is one of the major factors. So to conclude, integration is not just about efficiency, it's about resilience, and a health system that can manage a patient with infectious diseases must be better prepared to address individuals with obesity and other comorbidities. An African health system must not inherit fragmentation, but instead take on the opportunity to design systems that are people-centered, data-driven, and have a life course base. And we are playing this as enablers to help in the vision of universal health coverage and health sovereignty. Tackling obesity and multiple morbidity in Africa is not a lifestyle issue, it is a system issue. We must integrate primary health care and research around real patient needs supported by initiatives such as ourselves, and we not just manage the disease better, but build resilient, equitable health systems that will serve today and tomorrow. Thank you.
So I wanted to take this opportunity to talk about two areas, the clinical education and the patient burden. Because as we talk about the health systems and we have a lot of these larger initiatives, I want us to think about, and those are also in the room, but the panel specifically, what should we be training our primary care physicians to do? Because there's a lot. They almost have to know everything, right? They're the first point of contact often for a lot of patients that are coming in with whatever's going on. Because oftentimes, I think you mentioned earlier, they're not going to say, I feel like I'm overweight, or I feel like I'm fatigued, or there's some muscle aches, or there's something else that's bringing them in. And we now have to have these conversations with permission about what some of these underlying risk factors are, what are some of the health behaviors, and then what are some of these genetic factors or family history. So what advice would you give for those who are providing or developing clinical education in the primary care setting to be able to address the challenge of recognizing diabetes, diagnosing and treating obesity and NCDs? And maybe.
Yeah, I can begin with, I think, again, the point is recognizing obesity as a disease. I, in my university, have just one lecture on obesity during my 6-year formation. So, and my university, University of São Paulo, is the largest in Latin America. Probably it's 10% that have this one lecture. The other 90% don't have any lecture on this. So if we don't see it as a problem, then there's nothing we can do about it. And I think it was very good, some points that were raised here. I think that we, of course, doctors should know a little bit about the neurobiology of obesity. That's there's genetics, there's brain regulation that makes it difficult to lose weight. So it's not about, eat less sugar and you're going to lose weight and so on. There's a lot of regulation on that, but also they need to understand what Sarah said about asking permission the way it is. Like I receive a lot of patients that sometimes they can go to a doctor that's well-intentioned, but don't know how to talk with the patient. Oh, so you want to die, there's something, or something like that, more in a judgmental way in some way. So, but why he's doing that? Because he didn't learn this on the university. All that, I will say that 99% of doctors discuss obesity of what they heard on media, on social media, on newspaper, and not for what they've learned in the university. So I think those is the main issues. And another one is that the target of the treatment is not losing weight or to being lean, let's say like that. A lot of people think that for a good obesity treatment, you need to the person with obesity should go to a BMI lower than 25, and that's not the target. The target is to improve health and to improve quality of life. So sometimes the patient had lost weight, improved health, improved quality of life, but still has obesity, and the doctor will say, no, you need to lose more and more and more, and that also prevents people to continue on treatment. So I think those are the main points. But if we don't have education from the beginning, nothing will change, in my view. And even people with good intentions could do a lot of harms for people living with obesity.
You say it so well. So I want to build off what you said as well, though, because I think that absolutely I agree. I would say the advice that I would want everybody to remind everybody about is that we're all just people as well. And so I, as the patient sitting across from you, I am a person that's lived a big life, and you are a person as well. So even just starting there and de-escalating, because that noise of the media and what we believe to be true is a large part of what's in that room as well in those moments. And we know, as people who have lived with obesity and have had to navigate the system on our own, we can often come into those rooms with our elbows up, ready for a fight, because I might be there to talk about something. I've got an earache, but it turns into a conversation about my weight. So as much as you presented the scenario that I'm going to talk about my weight, that's part of our challenge as well. And I think a lot of what you described can also come down to just recognizing bias and stigma. And as Joe said earlier in the panel, it can come with unintentional consequences. You might have the best of intentions, but my invitation to all those primary care providers as well would just be to take a breath, be a human, but also recognize your own bias and stigma in those moments. And it's okay that you have them. What's not okay is to keep perpetuating them. You need to help build the space between you and your bias.
What I actually see as a priority is somehow to try to work together to restore the position, the image of the family doctors, of the primary care professionals, actually to restore. Because in a lot of countries, actually, the family doctors are the interface between us, people, and the health system. And the health systems actually were designed 78 years old. And nothing basically changed. So we haven't seen like a new design for the health systems. And what happens was to add other layers, but on the same foundation. And now we are, I think you mentioned that the obesity, it's a complex system, and I fully agree. But in most of the countries or territories, it's not complex, it's complicated or chaotic because of these add-ons actually to these basics. So, and this require a totally new way of thinking, and of course education is very important, and is the same. If you speak to, I don't know, oncologists, at least in my country, they will say that, you know, we are actually teaching students for 1 week in 6 years to learn oncology. So we really have an issue with the education curricula, but I think it's not enough. Because family doctors are part of the health system, unreformed, and with a really weak design, old-fashioned design, and is part, and this is what we are working on, is part of a very local social and geographic infrastructure. So we should think to them in this very particular organization.
Here now I'm speaking in from the perspective of Africa, where the health systems are really constrained, and the doctors may not be the only service providers. And in the context of primary health care, there has to be increased awareness of the service providers that are available. And in this case, they may be the nurses, they may be the clinic officers, or they may be the medical officers, so that they are well equipped to handle this. And here, information is very important, that they're well informed, and the system itself anticipates this, so that in the health system, they're able to take the measurements, or where they have the important parameters that the service providers need to capture, that these are captured. And this is to apply both for in the general clinics and in the specialized clinics, so that it's an integrated approach to combat the problem. Yeah. Thank you.
I wanted to take the opportunity, because my personal soapbox is women's health. And so we're going to open up for questions from the audience and online after this particular question. And so there are established sex differences in metabolism for women. We know that also this rise in NCDs in women's health when it comes to autoimmune conditions, cardiovascular disease, Alzheimer's, bone health, and osteoporosis. And so I'm curious to know, what work have your organizations done to address the unique needs of women when it comes to obesity, as those levels also, severe obesity disproportionately affects women more than men?
Yeah, I don't know if we've done anything specifically, but what I did want to, I suppose, highlight is just being in the world of obesity is I find women talk about it more than men do. Like, we find that when we're reaching out to men, it's always harder to kind of get them to engage or kind of get people, because I think as a culture, the diet culture world has been very much channeled towards females, women. And so I have been on a diet my whole life. Like, I can't remember not being on one. And so I think then we're constantly talking about foods we're eating and what we're doing and how we feel and all of that kind of thing. So I do find that I think things are geared more towards females for that reason, because it's kind of that culture that's been created. And I actually worry about that we're not engaging with men enough to support them because it's kind of not seen as a culturally acceptable thing to discuss or talk about or share as much. So I would say that there's probably quite a lot of support for women out there, and I'd like to see more for men, actually, weirdly. But yeah, that's just kind of my thinking.
Okay.
Yeah, I was going to say, you're not going to get a lot of men going to a doctor to talk about weight problems or whatever. Not at all. I wanted to link the two things up because I thought that the first point was about the physician and primary healthcare. I actually just question whether the doctor is actually should be the main focal point. I mean, it should be before that. So when I was talking about self-care, we were talking about the family, the individual, the community, and I think a lot of it starts there, and a lot of that is about awareness, getting better aware about a lot of issues, and empowering the community and community care. So I'm not sure it's about going to see a doctor. Maybe it's going to see a community group that deals with obesity or with other issues. The second thing is, doctors are not trained in nutrition. It's not even on, well, I don't know if it is now, but it's hardly on any curriculum. And that's one thing that needs to be discussed is about nutritionists. Yeah. I'll stop there because I think other people might want to talk. Yeah, I could go on for ages. But
maybe just to share my first town hall with the citizens in this village. So around European Code Against Cancer. So don't smoke, quit smoking, don't drink alcohol, be physically active. 12 recommendations, and usually, and I attended so many meetings about European Code Against Cancer and in general about cancer prevention, and the first recommendation is quit smoking, the second is quit drinking alcohol. So you can imagine how adherent people will be after if you start this way. And I went in front of the audience, around 120 persons, and I said, these are the 12 recommendations of the code. What are the most important for you? And guess what? What they choose? They choose nutrition, obesity, and physical activity. And this is how we started, and I didn't expect, actually, to be interested on this, and was a challenge, at least for the physical activity. Elderly people, a lot of comorbidities, but interested to become more physically active. And this was a challenge, and what we proposed to them was to try to play walking football. Walking football, is playing football without running, just walking. You're not allowed to hit the ball too hard, and it's not about physical activity, but about connection with the others. You have a reason to come together, to go to a sport hall, to spend 1-2 hours, and what we did was to put together, to your question, women and men in the same teams, playing some of the women for the first time, in this case, walking football, anyway, football. So it was a way, what I'm trying to say is that we started by listening the real needs of the people there, and then we co-create the design of the intervention, really context-specific.
I think I saw Dr. Thakker. Did you wanted to weigh in?
Yeah, sure. Thank you for tapping me. But I can't help but think about the blue ocean strategy overlaying the entire conversation of obesity from the panelists so far. And I just want to flesh out the ERRC canvas. I mean, if we approach obesity with the ERRC, I think we'll achieve so much. E stands for eliminate. You all know R is reduce, raise, and create. Now, I've been listening to the conversation and have read the WHO report, and the biggest thing on eliminate is stigma. Mm-hmm. The largest thing in reduce is the growth curve. We want fewer and fewer people moving into this condition. In the aspect of raise, everyone's talking about awareness, and rightly so. And then in the canvas of create is a model of integrated approach. a holistic care, which I've been hearing about doctors, nutrition, community care, and I think a fit for purpose healthcare system that will enable, detect, identify, and solve right from the beginning. And let's just be very clear, a lot of this is preventable, really, and we should prevent it because prevention is better than cure. But we need to get to it. And the economic burden of this is extremely high to the world. So we need to act with speed. Prevention tools are with us. There are some more complicated cases, but more the majority are preventable. So I think I would say that the canvas of ERRC overlaid with the WHO strategy will give us a huge progress. Thanks.
Okay.
Can I just comment on? I think that this is also a very good point about stigma, as women suffers more stigma on weight than men, and World Obesity Federation is working a lot on the stigma point. We have the idea of decreasing stigma in the long term, of course, but also to discuss a little bit. The World Obesity Day this year was about health system, changing health systems, because there's all this perception for a lot of people that, oh, it's just a choice, you can go to the gym, you can eat better. And for women, this is especially like perverse in some ways. Like they work, they get to work, and then they have to work again with the children, in the household, and so on. So what time they are going to do physical activity and to have good food, healthier choices, and so on. So I think things get mixed in this point, like more stigma in women, more difficulty to have all these lifestyle changes, and we have to tackle this. And I think your point raised is very important to do it even more, this discussion.
Can I add a little spice to the conversation as well? So in 2024, Obesity Canada produced a report called The Cost of Inaction, which talks about what it's costing Canada to not recognize obesity as a disease and treat it as the upstream factor that it is. The result of that research is that $27 billion annually is being lost in our economy. $6 billion of that, not that I have $6 billion in my account and just say, don't pay attention to that. Those are direct healthcare costs. The larger cost to our economy is what is lost by people not being able to show up fully as themselves, find employment. We have higher mortality rates, more disability rates, and when we dial in and we look at women, we have a double disparity. When we go into the workplace, we're already making less, and when I go into the workplace as a woman living with obesity, I make less even more. So we've got a double disparity. So the greatest thing that we can do is get loud, and we need to educate people. We need to educate not just our primary care doctors, we need to educate each other, because as people who have been steeped in diet culture, and that includes all of us, even if you have a fancy medical degree and I don't, that noise is very loud and very pervasive. For me and my personal lived experience, I lost a connection with myself. And until I had that reconnection with myself, I didn't even realize I was worthy to stand up and ask for the help I deserve. And now we have this real big confluence of everybody thinking they know everything and that GLP-1s can come to my door in 2 hours, and we've lost it again. We've lost the plot again. So I will just always maintain the greatest thing that we can do is have these kinds of conversations. Call obesity obesity. Call it what it is. It is a chronic disease that deserves the same care, respect, and dignity as other diseases.
It's interesting, and again, if there's anyone from the audience to raise your hand and a mic will come. I think there's a question up in the front. They'll bring for the mic so that we can get you online. And so even as you raised that point of it is complex because we're steeped in diet culture, which is in a way saying you can change this by how you eat. But if you have genetic predispositions, if you have hormonal imbalances, and environmental factors, there's certain things that an individual can't change through their diet. There's things that, require a holistic care approach. And so where do we balance that? And, hopefully we can touch on that. Where do we balance between having the medical side in the treatments and therapies versus the lifestyle side of what you can do at home, and when do you cross into that, right? When do you, after I've tried what I've tried at home, when do I now go into the medical field to figure out how can we do this with therapeutics and come back? So we can come back to that. And sir, you have a question.
Maybe a bit of a question might come out of it, but more of a comment. Great panel, great conversation. I think there's been some really great points that are raised. But I wanted to pull back to the question that you asked about, the role of primary care in obesity management here. And I think we've been in a spot with obesity where it's been evolving really rapidly. And for the longest time, to go back to the stigma piece and stuff, we didn't know who was responsible for it. And so doctors didn't want to be responsible for it because they didn't have tools, or we didn't know what to do about it. We didn't have effective treatments other than maybe bariatric surgery and those sorts of things, which are hard to access. And so there was kind of like this space for a really long time where no one wanted to touch that hot potato. And now things have changed pretty drastically. We know a lot more about obesity now. We have treatment options that are effective and those sorts of things. And so primary care is going to play a role in it, but I think we have to frame it appropriately. And the analogy that I use is we got to think of primary care as the general contractor. You're not expecting a general contractor who's building and responsible for building a house to do all the plumbing, all the electrical, all the other pieces to that, right? They are overseeing it. They know enough about all of it, but they're not specializing in any of it. So primary care has to be that general contractor. They're not going to be the dietitian who knows everything about nutrition. They're not going to be the person who's going to be able to deal with all of my mental health things that I want to talk about. But they know enough about all of that on the higher level so that they can help us, direct us to the right spots. And I think that's how we have to view primary care.
Thanks. Glenn, thank you. I really like that analogy of the general contractor because the burden is pretty high on primary care physicians. So, it'll automatically come up?
No, it is, yes.
Yeah.
Thank you, all the panelists. I was listening to your conversation and it was really insightful. I am a professor of medicine and currently the chair of the IDF School of Diabetes and work on education and a lot of things. I would just like to bring in the perspective of a clinician that what goes in our mind when we see a patient, because a lot of being discussed with the stigma and the bias and who brings it, the stigma. So let us think about it. When we consider diabetes as a disease, we want to conduct screening camps to detect diabetes. We want to conduct screening camps for hypertension to detect hypertension. But we don't want to initiate conversation on obesity when we see a patient right in front of us is overweight. And why do we bring stigma and bias with this? Because we know right now the science says that the benefits of different weight loss. 5% you achieve this benefit, 10% this benefit, 15% more benefit, 20% more benefit. We have tools as well. Everyone may not be a candidate for the GLP-1. Everyone may not be able to achieve that kind of physical activity. But there is a lot of evidence that shows that even if you lose 2-3 kg of the weight, there can be a significant benefit in your metabolic health. So I see if though I respect the patient's choices and the decisions, but I see it as a missed opportunity if I do not engage myself and do not initiate a discussion on the obesity and make the patient aware who is sitting in front of me. Because I believe this patient may be a very educated one, may be having obesity and maybe may not want to take any action, but at the same time, the person sitting in front of may be a person who doesn't know anything about obesity and its harmful effects. So when we invest so much in screening for the diabetes, hypertension, dyslipidemia, other disorders, why do we want to miss opportunity to initiate any discussion on obesity when we see the problem right in front?
I'm going to add a bit to that so that you can also speak to, even to that tone. Could you also, in your response, talk about iterative wins as opposed to the big win? Because somewhat of what I hear there is the assumption is 50 pounds or 100 pounds as opposed to 5 or so. So maybe to speak to that as well.
Yeah, I think my comment on that is I don't disagree with you that we shouldn't miss opportunities and that if we see someone sat in front of us that has excess adipose tissue, we know they potentially are at increased risk of all sorts of different, diseases, comorbidities, etc. I think the bit that we don't know is how long has that person lived with obesity? Is that person sitting with obesity in front of you, have they lost 100 pounds before they're sitting in front of you today? Have they run to their appointment today? Have they cycled there? Have they really struggled to get there? Are they in pain? It's understanding all the other things. And just because obesity is visual, we make assumptions. And for me, that's the biggest bit we need to come away, and that's where the stigma comes from. Because, you know, I live with obesity right now. However, I've lost a significant amount of weight, and I'm still sat here living with obesity. I do triathlons. I do lots of active things. But actually, when you would look at me, you would not imagine those things, I would imagine. So it's about understanding the individual in front of you. And then, yes, please, you know, if they're happy to have a conversation, do. But don't assume that this is somebody that sat there without doing anything. And I think that's the bit that we struggle with, is doctors, you know, not wanting to tar brushes, but do make these assumptions. You know, more recently, on a personal level, I was told I had fatty liver disease. No one has ever tested me for fatty liver disease. No one has ever done any diagnostics. And I actually, fortunately, had an MRI and I had my liver tested, and I don't have fatty liver disease. That was an assumption that was made and put on my medical record with absolutely no justified reason for it because of my size. And I think we need to stop doing this. And that's my concern, is that we visually see something, we make those assumptions. So, yeah, those are my thoughts.
I love what you said about iterative wins as well, and I want to pick up on that from that conversation as well. We have these statistics that we repeat, that this 2, 5, 10%. I would challenge you, citation required, because a lot of that has also just been passed down for generations as a true belief. And I can say that with confidence because I am working with researchers right now that are looking into what are more reasonable targets for people to have in these conversations as well. Because again, there's a lot on primary care. There's a lot on those family docs. There's a lot on all of us when we're having these conversations. But moving the conversation away from body size and weight is what we foundationally need as well in these conversations as we're challenging our bias and stigma. We need to find those other measures of success and, again, help people reconnect with their sense of self. Because that measure of success might be you can now get down on the ground and play with your grandchildren when you couldn't do that before. You can now qualify for a knee replacement. There's so many wins that people are dismissive of because diet culture has been so loud and told me, to your point, you know, it needs to be 50 pounds. And when I was in my most frenetic state living with obesity, I genuinely felt like I was taking a teaspoon out of the ocean when I got my 5-pound bookmark. You know what I mean? Like it erodes your sense of success. It erodes your sense of self. And the best thing that you can do as primary care doctors is ask for that permission and then find out about what is important to that person and use those as the measures of success.
On the internet, there are lots of comments supporting the comments about education in schools for nutrition and stigma, and there's a number of comments around using technology for primary care, to use AI to be able to personalize advice to patients. So yeah, I'll give it to Joe.
So I will ask one quick question before you go. Ledin, what's our leeway in time? 5 minutes, all right.
I'm a medical doctor from Zimbabwe, and I'm also in the health systems and policy space. And this question is mostly to the panel who have got organizations that work on the African continent. And my question is that, given that there's a triple burden of disease in many African countries, and there's a non-communicable diseases like obesity, infectious diseases, and trauma, have you seen efforts to generate or use data that map the drivers of obesity at a systems level? And how can governments better integrate this type of evidence into primary healthcare planning to more effectively target NCDs? And this I ask because my culture states that if you get married, you have to gain weight. It's a show of you having a comfortable life. And my mother will expect me to have gained weight if I get married. So how do you address such issues?
Dr. Thakker? Oh, I think in the
Sure.
back.
That's a really good question, and I think the doctor in Zimbabwe raised an important cultural matter, and I did say that raising awareness is important, and sometimes we've got to deal with this in a sensitive manner. When then someone gets married and they don't get weight or they don't gain weight, it's like, is there something wrong? And are you living comfortably? Are you eating well? It's coming from these many years ago. We used to deal with malnutrition, and we still deal with a lot of malnutrition in Africa. But again, raising awareness, having leaders in the communities, and even having people like religious leaders, community leaders, group leaders, all to be involved in what is health and healthy living is critical to move with that. And just to let the lady from Zimbabwe know, we have a group called the Coalition for Women's Health in Africa, COHA, and I'm very happy to connect with anyone who's doing work for women's health in Africa, including NCDs in that space. Thank you.
For those of us who are concerned with stigma and bias, I want to be clear from the question prior that I don't think there's any suggestion that primary care providers should not engage with their patients about their body weight. It just, I think those of us that are advocates believe that there should be a different conversation taking place, and it should be approached in a more personal manner. I will tell you, my doctor's never shamed me about my blood pressure problem, but my doctor has definitely shamed me about my weight problem. So you have to approach that issue in a different way with them. And it is all about compassionate, empathetic ways. And so maybe a question to Lisa or maybe Sarah, have you seen models or systems that teach primary care providers to have better conversations with their patients, like give them the skills? Because it's not only about understanding obesity, it's actually understanding about how to talk about obesity. So curious if you've actually seen one of those models. Do they exist, or is that something as a community we need to work on?
I think two things can be true at the same time. I think we need to, as a community, continue to work on those. But absolutely, at Obesity Canada, education is a huge part of what we do, and a large part of our education offering has to do with how to action this in the room. And we recognize, again, we're just two people in a room trying to have a conversation. So we are putting together even more information around what are those competencies that really help to move what we know from the clinical practice guidelines into that exam room, so that we can really arm people with those right kind of competencies. Because you're absolutely right. Like, not everybody knows how to have those moments or have those spaces. And it's another thing that we need to educate on. So check out Obesity Canada's education's offerings.
And I would just say, yeah, I mean, it's the most commonly asked question that I get is, how do we open up those conversations and how do we do it? So we actually created a Language Matters obesity guide in the UK, which was about framing kind of language questions, how to open up those things. So that is something that we've done. It's not something that I would say is used enough yet, but it's something we're actually redoing at the moment as well, because now around language around medications and things, but it's, yeah, there is a guide that can help support healthcare professionals.
Is from the Stop Obesity Alliance. They have a Weight Can't Wait discussion guide that talks to primary care providers about how to have this conversation. And again, people need to have the conversation, but how you can have it in a way that's not further stigmatizing.
Yeah. We have one last question in the back.
Hello, good afternoon. I'm Maria Castelló from Instituto Clemente Estable, Montevideo, Uruguay. And listening to you, I find most of the things that you propose to combat obesity in some way are part of a common denominator of brain health, cardiovascular health, and other aspects of human brain health in general. And so one of the things that are very important in all the cases is nutrition. And I was wondering if you are thinking about the possibility of impacting strongly in the companies. You know, even tobacco companies are investing in cookies that we all know are very bad to our health. And so if we change our habits from the beginning, from birth, not including salt, not including sugar, we would be making a great impact on everybody's health, not only concerning obesity, but global health and in integral health in every person. So I was just wondering if you can comment on that. Thank you so much.
I'll take one quick comment.
Yeah, we're working a lot on all this discussion on prevention, on ultra-processed foods, and on sugar taxation, and that's something also related to the declaration that will be launched on Thursday that missed a lot of points, specifically about taxation. So we should focus on changing the system, including the food industry, but it's very difficult to do so because there's a lot of economic points being held, but we're trying to do, and then again, it's not about individual choices. We should change the whole system so it's easier to people to get better foods. But certainly part of the solution comes from a change in this environment, coming from a global coalition and not doing individually in each country.
This is really, I'm sure we have some more, and of course we're going to the next session, but I would like to ask each person on the panel to briefly give what is the key intervention you feel is the most important one that we should focus on. Everybody can have their own, but what should we be focusing on in your mind? What is that primary focus? We'll start with Dr. Thakker online, and then we'll come down.
I think keep the conversation going, keep the partnership going. Let it be very clear that there is a huge amount of this obesity issue that is preventable. Empower the health worker community health workers included, because together we'll be stronger and we can deal with this. We should not have it as an issue in the next, I would say, 20 years. Thank you.
Thank you. And Doctor?
Well, I come in from the point of integration, and that is promoting integration, an integrated approach in the health system, and looking at the individual as a whole, instead of just looking at one problem, obesity. Over.
Maybe we're talking about primary health care, but I wonder whether it's also about shifting more towards community healthcare and the family and information and empowerment there.
I think for me, it's just coming back to one of the topics we've talked about a lot today around recognizing obesity as a disease, because I think until we do that, we're not going to get the actions that we need. And I think globally, this pitch is really urgent because more than a billion people already live with obesity. And by 2035, that number is likely to raise to nearly half of humanity. So I think if we don't recognize it, and obviously right now the political declaration is falling short of that, unfortunately, without course correction, we will risk leaving half the world behind. And I think we need to recognize that.
For me, the keyword is personalization, and in particular, personalized prevention. This is an emerging concept coming in the EU, and personalized prevention is actually intersecting primary, secondary, tertiary prevention, and it's a way actually to say that we are now able to collect many data from by measuring or considering health determinants, from lifestyle to social factors, moving to health system, environment, and genetic and biology factors. And if we will apply the personalized prevention to obesity, we'll be able to, first of all, to understand what is important for us as individuals, what is the context we are living in, what are the characteristics of the health system, of course, the physical environment, and very important, biological and genetic factors that can influence the development and the outcomes of the obesity treatment.
have a couple, but I'll squish them all together, I promise. To me, I want everybody to remember that the challenge is big, but the opportunity is truly bigger. I really feel like we have a once-in-a-generation opportunity here to help a lot of people see things differently and therefore impact the systems and impact change. But all of that really is being stymied by bias. Bias is influencing policies, it's influencing how benefits are chosen, and it's influencing way too many clinical discussions as well. So I really hope that we can focus on the opportunity at hand and really help everybody shift from judgment to understanding, and from stereotypes to science, and from isolation to collaboration. That's the last time I'll use it today, I promise.
Yeah, I agree with Sarah. I think, first of all, recognizing obesity as a disease on its own and should be looked as its own and its own. So I think that obesity is everywhere and nowhere. You know, like when we are discussing NCDs, we are discussing obesity. It's in the room, but nobody's talking about. That's the point, you know. So we should put obesity in the focus. And I will finish with the 3 zeros that World Obesity Federation. It's a goal for the future, very difficult goal, but let's try to do it. 0 stigma, 0 increase in prevalence, and 0 barrier to access. I think this we should focus, and let's try.
I'm going to take liberties as a panel, as the moderator, to give my preference, and it's alignment. Kind of to the point of the collaboration. I think, as you heard, we just got 7 different priorities, right? None of them are wrong, but we have to find alignment even when it comes into our care. What is the priority of the patient? What is the priority and the goal of the healthcare provider? What is the priority and the goal of the health system? And find that alignment, because I feel like that's where we start to move the needle forward. All of them are good, but sometimes we can only focus. So once you find what that alignment is, then you can all be working together in that common direction. So thank you so much for all of your expertise and your insight. Thank you very much, Dr. Thakker online.